that's about switch off my phone. That's okay. So this is about the heart failure and coronary artery disease in the African population. It is quite significant, to address this specific problem, because when I've kind of designed the opening slide, should be very significant. Because Africa is that heart of the world that gives us the maximum resources in terms of valuables, diamonds, wildlife, and everything. Yet, you would very often see people from the very same continent constantly struggle to get a decent echocardiography, get access to basic medicines. Only private clinics in certain countries in the North Africa region will be providing you quality, you know, medical care and medicines. And it is quite disheartening to see that how basic medical services, which have been routine in other parts of the world for almost the last 30-35 years, is yet scarce and wanting in Africa. So that makes me address two very basic, common, and high prevalent condition in the African population, which are heart failure and coronary artery disease. Okay. Okay. Yeah. So, what makes the heart failure unique in the African population? So, it is an earlier onset heart failure in their 30s and 40s. A lot of it has to be attributed to hypertensive heart diseases, rheumatic heart diseases, um, coronary artery disease in the younger African population because of their food habit. Couple that with the later reporting, because they would often report to you with such advanced valvular diseases that the valvular disease has now progressed to something like an intractable heart failure. So much so that that heart failure does not have a medical answer, does not have a common surgical answer, as in changing or replacing or repairing a valve. And the only option we are left with is potentially to offer them some form of heart transplant or implantable device therapies. A poor access to imaging and other advanced diagnostics. So it is very often seen that people coming from the African continent would struggle with basic imaging facilities like a transesophageal echocardiogram or even a good quality transthoracic echocardiogram, which is a very basic requirement or kind of an OPD tool today in any cardiology clinic anywhere in the world. I'm not only talking about the advanced or the developed Western world, even in places like Asia, it is very common to at least have 3 to 4 echocardiography machines in a cardiac OPD clinic. The problem is often underrepresented in literature, in studies, in registries, partly because of a lesser focus to the region. And then treatment regimens are often very haphazard. It is not unlikely to see people being referred to us with advanced heart failure or coronary disease on medications that are not suitable to their needs. So these are the few reasons that would make the heart failure burden in Africa definitely more wanting and stark than that in other parts of the world. So coming to the causes, I would later come to one of the registry studies that has been done from Tunisia. So the leading cause for heart failure in African population is the hypertensive heart disease, attributable to again to poor medical access, poor recording of blood pressure in the outpatient clinical setting, inadequate availability of drug, inadequate prescriptions, not the correct medication for the correct population, and all of which compiles to give a very high incidence of hypertensive heart disease. The second would probably be rheumatic heart disease, as Dr. William Boyd said, that rheumatism licks the joint to bite the whole heart. So rheumatic heart disease is very prevalent in sub-Saharan Africa. Many different forms of cardiomyopathy, some of which have a genetic origin, some of which are attributable to the African population because of the genetic predisposition. And then there is obviously the double trouble of the infectious diseases, tuberculosis and HIV, which are present in large number in the African population. Coming to the double trouble, let us be very frank and accepting that tuberculosis and HIV today are a global threat in terms of cardiomyopathy in the African population. Uh, without being overtly sensitive about spelling the HIV word, I would just like to put it out in the open. And last but not the least would be the migration of the younger population in Africa towards the bigger cities would mean that they would contract the same different urban diseases as in the Western population, which is atherosclerotic aortic or coronary artery disease, which goes on because of the underreporting, because of the later reporting, goes on to give frank, full-blown heart failures. So this is one of the articles that came up. This was during my training days. Heart failure disease in African perspective, or probably very early career stage. It came out in 2020 out of Tunisia. And it took into account some 13 African registered studies from different regions, from the Middle East, North Africa region, from the Sub-Saharan Africa, from the Western Africa, Eastern parts. It took into account many different countries. And one of the leading causes, if you see, I will just use a pointer. I'm so sorry. The pointer. Yeah. And one of the most common causes would be the hypertensive heart disease, followed by cardiomyopathy. And it is only much later. Yes, in some parts it is significant, the rheumatic heart disease, but in many other countries they are not as significant. But hypertensive heart disease, almost in every single African country, has got to be the leading cause of heart failure in the African population over a 10-year registry study. It was 13 different registers from many different countries. Yeah. Yeah, so this would be a very rough map from the same study if you want to believe that green would be the best conditions, and the more dark they get, which would be part of the East Africa and the southern part of Africa and kind of the sub-Saharan Africa, the problems are definitely more stark than it is in other parts. Maybe in the northern Africa, in the western part, as well as some places around the Congo, Sudan, Central African Republic, Cameroon, these places would probably have a slightly lesser predilection of heart failure diseases and heart failure clinic admissions. So these are basically prevalence of all admissions to the cardiology units all across Africa, which come with heart failure. And the burden you would see would be about 10.8% in Tunisia, about 30% in Cameroon, and in East Africa, it would be almost more than 50%. So, how do we curb this problem? I mean, we appreciate there is a problem, but how do we curb it? So, one would be a very routine, standardized blood pressure monitoring and very good quality of care in the GP clinic level. Second would be setting up remote heart failure clinics as telehealth clinics, introduction of the newer drugs or goal-directed medical therapy for heart failure, better dyslipidemia control with newer drugs like PCSK9 inhibitors. Why do I say dyslipidemia? Because there is a very strong predominant non-vegetarian food habit among the African population, along with a reasonable amount of consumption of heavy meats, which predisposes a certain part of the population to developing heart failure, endocrine heart disease, coronary artery disease, so on and so forth. Good quality echocardiography at the outpatient level and early referrals. Early referral has got to be the key. More often than not, I have stressed upon the fact that an early referral can at times save an entire surgery. I mean, that is how I have practiced my medicine. So I have never practiced my medicine in the number of procedures that I have done, which some of which Varun would be aware from his Jivo experience with us. So early referral at times without wasting a lot of time putting them on archaic therapies like putting heart failure patients on digoxin and or dated non-specific beta blockers is really not going to help them much. On to the next slide. So what are the treatment strategies that we have for a specific problem? For valvular heart disease, it would be an early valve repair or replacement. It would be providing very good quality antibiotics for prophylaxis and prevention of group B streptococcal infections. Heart failure medicines for manageable heart failures. For intractable heart failures, there are some implantable devices. And choose the right device or the right therapy for the right patient. Always have a heart team approach, which has a physician, which has a cardiologist, which has got a cardiac surgeon, anesthetist, respiratory physician, intensivist, and a bunch of other people who are ready to sit down, debate, argue, at times fight each other to give you the right therapy. A heart failure cannot be treated by a cardiologist alone. You walk into his clinic, he writes you something. It cannot be treated by a cardiac surgeon alone. It cannot be treated by a physician alone. It cannot be treated by an intensivist alone. So there are at least got to be six different specialties: cardiologists, cardiothoracic surgeons, respiratory physicians, intensivists, general physicians, and kind of either a family medicine or a preventive physician. These six group of physicians at least got to sit down and form a heart team and decide what is the best way forward. The same disease in a 43-year-old patient vis-a-vis a 73-year-old patient, the very same disease might elicit a very different response from a heart team. At 43, we might be offering him or her an open chest, crack open, total arterial, coronary artery bypass grafting. At 73, we might offer the same disease in a different gentleman, a completely different therapy. At 83, it might just be tender love and care, good quality medicine, improved quality of life years. That's about it. So a heart team approach is the absolute key to, tackling whatever modality of treatment you should undergo. Coming to the medical treatment, well, the medical treatment has completely changed in the last few years. If you look at it, so there are SGLT2 inhibitors, which are basically the flozins or the empagliflozin, and specifically speaking, dapagliflozin and empagliflozin. Remember very easily that when you cannot choose which one over the other, choose EMPA, because empagliflozin has been seen that its dose does not need to be adjusted even if at a GFR or a glomerular filtration rate less than 30 ml per minute. So even if there is a chronic kidney disease or some form of vasculitis or vasculopathy, which is, or a diabetic patient who is predisposed to a diabetic kidney disease and has to be put on a long-term SGLT2 inhibitor, it is always preferable, at least in our practice, that we use dapagliflozin definitely more than dapagliflozin, though dapa was the first molecule that came out in the same subset. The next should be ARNIs or angiotensin neprilysin inhibitors, angiotensin receptor antagonist and neprilysin inhibitors, which is basically a combination of sacubitril and valsartan. They cardinally work by blocking the neprilyzing and increasing the natriuretic effect of the natriuretic peptide. They prevent the harmful remodeling, and they have largely replaced ACE inhibitors as the first line or choice drug for heart failure. We have traditionally used mineralocorticoid receptor antagonists like spironolactone, but there is a new group of drug called non-steroidal MRAs, which is represented by finerenone. And I have intentionally displayed a few brands on the right side. So these are kind of very international European manufactured brands, largely available across huge stretches of Africa after reasonable research has been found. And that is the reason I have, displayed their pictures. Not that I have any, disclosures, or I do not consult any of these companies in any independent capacity or even through official capacity. So finerenone comes as Carenda 10 milligram, and these are kind of the standard adult doses that have been displayed here. Soluble guanylate cyclase stimulators like vericiguat. So riociguat is initially used for the class 4 pulmonary arterial hypertension or pulmonary chronic thromboembolic pulmonary artery hypertension or any vascular disease in the pulmonary circuit. Its newer variant or vericiguat, which increases the cyclic GMP levels and improves the vascular function, has been used for people with reduced ejection fraction. Anybody below a 45% ejection fraction within heart failure can be put on a SGC stimulator like vericiguat. And then there are investigational molecules like the omecamtiv mecarbil, which is basically part of the galactic heart failure study. So these are still in the cardiac myosin, inhibitor. So these are basically cardiac myosin activator. So these are basically investigational molecules still in the lab, still in research, still in studies, and yet to probably hit the shelf of the markets. But remember, in a clear way that all these medicines are reasonably good for those kind of heart failures which are still in the 25 to 50% ejection fraction or 25 to 45% ejection fraction. Anything below 25% would need a very specific attention. Coming to the surgical modalities, so the surgical modalities are varied. So starting from a percutaneous balloon for a mitral valvulotomy, because mitral stenosis because of rheumatic heart disease is one of the leading cause of heart failure in the third world. Places like Africa, places like some parts of Asia still continue to be the kingmaker. So they are the most common cause of heart failure. So a INU balloon or a percutaneous mitral valvulotomy balloon for a mitral valvulotomy to relieve the mitral stenosis is still a very efficient therapy for any heart failure patient because of valvular heart disease. The next should be an implantable heart valve. I have just used a mechanical valve for the significance that heart failure in these valvular heart disease patients present at a much younger age when the options are limited, and probably mechanical valve, which is a lifelong valve, is one of the options that we have to seek, despite knowing that it will have the disadvantages of being on lifelong anticoagulation, bleeding risk, so on and so forth. Next would be the ICDs. I would absolutely like to educate people on the use of ICDs, because ICDs are devices that are not meant to treat heart failure, but they are meant to treat sudden cardiac death, which can rise from heart failure, which can become a precursor to your death because you have a heart failure, because you have an irregular rhythm. So ICDs can prevent such deaths. ICDs are not per se treatment modalities which will improve the pumping action of your heart or improve your heart failure. Last but not the least, the most intensive of these implantable devices is this HeartMate, or the HeartMate 3 specifically, which is an LVAD, left ventricular assist device. It is expensive, but for people that have gone into intractable heart failure, cannot right away get an organ transplant because of many different reasons, because only having a heart failure and an intent to have a heart transplant will not make you a candidate for a heart transplant. So you ought to be bridged to it if you are in a very bad shape, or if you are kind of a reasonably older gentleman that does not want a heart transplant and only wants to use the LVAD as a destination therapy for some 10-15 years. So then LVADs are the kind of upcoming modality of treatment. Yes, it is expensive. Yes, it is intensive. Yes, it needs a lot of effort, a lot of resource to be pulled in by the hospital to manage one such patient. But if the heart failure is intractable and really a risk and threat to your life, even with an ICD, then LVAD may be the answer. And finally, the holy grail of heart failure is the heart transplant. So this on the right side is basically a heart that has been mounted on a Transmedics organ care system, which has been harvested from a donor to be implanted in a recipient as it is being transported. Coming to coronary artery disease, I would just use these three independent pictures. This is a book called The Heart of Africa. This is this article that really motivated me to speak on this topic, which is the pandemic of coronary artery disease in sub-Saharan Africa. What the clinicians need to know. In this appalling number, there is about 1 million deaths each year in sub-Saharan Africa owing to coronary artery disease, which accounts for about 13% of all deaths in the region. To put into perspective, the entire region would have only about zero point 0.5 or half the amount of cancer deaths. So cardiac diseases which are preventable are killing twice the number of people each year in one specific region. Um, so this is a slide that is more for the general practitioners or the physicians as to how do we identify a heart attack in a men and women. So in males, it would be in heavy, painful chest, cold and sweaty, pains in the neck and the left arm, sudden feeling of nausea, sudden onset of symptoms, shortness of breath, extreme lassitude. While in women, it might be quite subtle. It might just be a flu-like symptom, a little bit of fever, feeling of indigestions, or feeling like reflux, symptoms may be present subacutely or may present for a few days and may often be misinterpreted as a heartburn rather than a coronary artery disease. So, coronary artery symptoms in women in diabetics are much more subtle and have to be picked up with much more higher index of suspicion. This is a very basic algorithm of how a heart disease or a heart attack can be managed in a resource constrained setting with a single drug like aspirin. If there is an ST elevation MI or a non-ST elevation MI, and you are in a situation where a PCI or a primary coronary intervention is not possible in the next couple of hours, the only option we have in hand is basically to introduce medical therapy where you load the patient with 600 milligrams of aspirin and 300 milligrams of clopidogrel or a second line antiplatelet drug. So these are some of the antiplatelets and the recombinant tissue plasminogen activators which are available all across Africa. So it's basically aspirin, clopidogrel, which comes as Plavix, which is a Sanofi thing. Brilinta, which is again ticagrelor, which is an excellent drug for non-ST elevation MI. And then there will be the injectable tirofiban, which is again a kind of a magical clot buster drug used in the acute myocardial infarction setting within the first 20 to 48 hours. And then I understand it is limited in terms of its availability, but alteplase or a recombinant tissue plasminogen activator or a kind of thrombolytic agent, which in a resource constrained setting can give very good quality microvascular revascularization, almost at times giving as something as good as a TB2 or a TB3 grade flow if given at the right time. Coronary artery disease, you always got to know the signs. You always got to be careful of them. Shortness of breath, any fatigue, any chest pain, sudden nausea, vomiting. You always got to suspect an heart attack. How do you prevent it? Healthy eating, managing stress, giving up on smoking, a reasonable amount of daily walking, keeping a check on your weight, and kind of knowing your blood numbers more regularly than others. How to treat it, and you have to be very careful if you've got any family history, any first degree relative that has had a heart problem. You got to be somebody who's very, very careful, who's not smoking, who's keeping a healthy weight, who's moving around every day. Just some basic habits. Something as basic as just walking to work or cycling back from work, that would be kind of de-stressing yourself, exercising yourself, keeping your weight in check. One single thing like cycling to work and back can kind of give you all these benefits. How do we treat it? So initially there are lifestyle modifications, we put you on medications, we can try to know about your diabetes and your cholesterol levels. We kind of want to kind of manage them and put them in a rational or more regulated pattern. And then obviously there will be procedures and surgeries which can be either a coronary stenting or a coronary artery bypass grafting. This is a very common food chart that I show people, that you need to have two or more plant-based legumes, three or more fruits, four or more vegetables, and five or more different kind of whole grains in your diet every day. So this is kind of the vegan food pyramid of 2, 3, 4, 5. Two legumes, three fruits, four veggies, and five grains. These are some of the common blood tests that every patient who's suspected of coronary artery disease should have with him, which is a full blood count, a look at his kidneys, livers, definitely look at his cholesterol levels, look at his clotting numbers in terms of his APTT, INR, if he or she is on any anticoagulants. Definitely look at his HbA1c to have a gauging of his or her glycemia level or his or her blood sugar level, and then the brain natriuretic peptides, either BNP or anti-proBNP, and a highly selective C-reactive protein to understand if there is any underlying inflammation which is kind of hampering him or her, giving rise to a hotbed for formation of coronary atherosclerosis and coronary artery disease. Well, definitive treatment options can be multiple. They can be either stenting or coronary artery disease or coronary artery bypass grafting for coronary artery disease. There have been multiple data from the Syntex Nobel Pre-Combat Excel trial that have been synthesized, and it looks like that the coronary artery bypass graft has a fewer adverse event at 1 year, lesser chances of revascularization because of stent blockage or because of graft failure. They are generally more durable, though they are generally a little more risky in the hospitalization period. During the hospitalization, they might need a little more care. There might be a slightly higher 30-day kind of adverse event in the cabbage group, because something as small as a surgical site infection is basically a morbidity within the 30-day period. So 30-day morbidity may be more. The first month may be difficult after a cabbage, but cabbage lasts long, has lesser chance of revascularization, graft failure. You will ultimately have better quality associated life years. It may be the initial 2 3 weeks, maybe hiccup for you, but just to fear about that and completely give up on it would probably not be the best situation. Whereas PCI has its own merits. It's a very quick procedure. The first month recovery is almost instant. You are expected to go back home right away. It might be a bridge to a later interval CABG. It might be the destination option in older people who are not fit enough or who are extremely sick. But today, I would say that nobody is too sick to go under anesthesia and not revert back from it. So, anesthesia, cardiac surgery itself, the traditional cardiac open cardiac surgery itself has evolved so much that it continues to be safer each and every day. So basically, we need to have a very good assessment of your angina or of your chest pain. We need to follow it up with a angiogram. More often than not, we need to do some additional fluid dynamic studies like fractional flow reserve and basically dimensionless ischemia free index time. We need to know what is your FFR. We need to know whether you would really benefit from a coronary artery intervention or a coronary artery bypass grafting. And all this put into place, when we synthesize all this information, we do a proper syntax grading for you, and we score you on a syntax score as a low syntax score, moderate syntax score, or high risk syntax score. That is 0 to 23, 23 to 32, and more than 32. The higher your risk factor in the syntax scoring, the worse your coronaries are, the better you do with a coronary artery bypass grafting rather than a stenting. But if you have a low syntax score, if you're somebody that has a more acute problem that needs an acute solution at this point, probably stenting might be a good option for you. Older people, frail people, stenting might be a good option for you. You want a very young one to buy interval period before he goes a definitive procedure. Stenting might be an option, good option for you. Well, as heart transplantation remains the holy grail of heart failure treatment, the absolute epitome of coronary artery disease would be a coronary artery bypass grafting with a total arterial grafting using both the left and the right internal mammary arteries, which is also known as the BIMA or the bilateral internal mammary artery configuration of CABG. There has been a study between 2013 and 18 where they've compared multi-arterial graft CABGs with percutaneous coronary intervention, about 850 odd patients in each arm. And there was only 13% mortality vis-a-vis 26% mortality in the stenting group at 1 year. There was 28% adverse events in the CABG group vis-a-vis there was 60% adverse events in the coronary artery stenting group at 1 year. And it has been published in the Annals of Thoracic Surgery. So cabbage with arterial conduits in patients with coronary artery disease have improved the survival and reduced the adverse effects. All studies that the stents or the interventionalists have come up are not superiority trials, they are non-inferiority trials. And the best that they have said is percutaneous coronary intervention is not inferior to coronary artery bypass grafting. There is not one study to this date which is not hugely criticized and taken down because it had serious industry involvement, which has gone on to say that PCI has been better than CABG. So if they say an eye for an eye, always say an artery for an artery. An artery has been blocked, always bypass it with an artery. Rather than getting extremely fixated about whether it is going to be a robotic surgery or a telesurgery or a minimal invasive surgery, I still go on to say people, yes, we do offer minimal invasive coronary artery bypass grafting for the right anatomy. You go to any big meetings, whether it is the ISMICS meeting, which is the worldwide the biggest meeting for minimally invasive cardiac surgery, and when you met some of the thought leaders in this, I mean, people like Gianluca Torregrossa, people like Piroz Deviarwala, back of the room, they would say that, we still do struggle with the right side grafting using either a robot, double docking robot, or a minimal invasive coronary approach, and which is not untrue, which is not untrue, that there are certain problems which are best addressed uh, with the traditional cardiac surgery. I always say for younger people, the focus should be the quality of the grafts. Getting a Lima vein robotic CABG is worse than getting a total arterial Senate stenotomy CABG. And I've always maintained the status quo. At times, I have been very vocal about it, about the quality of grafts rather than the technique of grafting, because trust me, your surgeon is at a better position or is a better decision maker for your modality of surgery rather than the quality of grafts where you are getting a compromise. Thanks a lot. Any questions, I'm more than happy to answer.
Thanks, Dr. Biswarup,
Yeah.
for a very informative talk. So, sir, around the wall repair strategies, wall failure.
Yeah.
So, especially, I have a question, especially in case where.
Allow me a moment to drink a cup of water.
Okay,
I've been
okay,
speaking long. So,
okay.
so
So,
sorry.
sir, my question is, let's say there's a patient and the doctors are recommending wall repair. So, to be
Mhm.
specific, let's say it's a tricuspid wall, and the options available are the mechanical wall, the
Prosthetic valve.
bioprosthetic wall, and tear as a therapy. So, which is followed and when, and there's pros and cons of all three.
Uh, See, tricuspid valve is more often repaired than replaced. Point A. Even if it is a moderately aged patient, someone in the 50 to 60 age group, I would probably say that a tricuspid valve replacement, if at all necessary, would probably benefit from a bioprosthetic valve more than a mechanical valve, because it is a low pressure circuit on the right side of the heart, so the wear and tear of the valve is much less. Whereas for a mechanical valve in that position, unless absolutely necessary, there will be very high risk of thrombosis and clots because it is a low pressure circuit. So the gradient across the valve is low. So there are chances that there will be small local eddies or eddy currents that will form and that will give rise to clots. So and this can be life threatening because if this clot slips into the lung, it can give rise to pulmonary hypertension, pulmonary embolism, and can be really deadly. Um, so basically, it can give what is called as a lung stroke. So, having said that, I would feel that tricuspid valve is best repaired either with the traditional De Vega repair or with an annuloplasty ring. If not, if at all requires a replacement, preferably for anybody older than 40 years of age, I would probably put a bioprosthetic valve. Mechanical valve in the tricuspid position is highly unlikely. And coming to tear or transcatheter edge to edge repair or the tri clip or the new magic therapy, I would be very, very wary of it. Because in mitral valve repair, the transcatheter edge to edge repair has a name which is called as mitra clip. To the surgical community, the transcatheter or the edge to edge repair of the mitral valve or the Alfieri stage is the ultimate, it is the ultimate bailout stage. When you've opened a mitral valve and you have no clue about it, or you are extremely limited in your armamentarium in terms of repairing the mitral valve, you do an Alfieri stitch. There will be half a zillion methods across the world: Roman arch technique, sliding annuloplasty, triangular resection, quadrangular resection, annuloplasty after a sliding resection, kind of neocordy implantation. There will be half a dozen methods repair the mitral valve. And you would do an Alfieri stitch only if it is a very extreme valve, um, and you have nothing to do in terms of repair, or replacement is not an option because of financial constraint or some other anatomical, abnormality which precludes or predisposes that mitral annulus to rupture and or have a near certain death. In those cases, I would rather say that why intervene at all? And today, with the amount of imaging, with the amount of pre-operative planning that we have, we can nearly be extremely sure about the anatomy that we are going to encounter, about the mitral annular calcification. We can have multiplanar three-dimensional reconstructions. We can look at the annuli. We can look at its calcification. We can look at a mitral annular dysfunction. We can look at a dissociation of the mitral annulus, as it is called, MAD. We can look at a host of other things to decide our plan early on. More often than not, you would have heard from us that rheumatic valves don't hold good in repair, and so replacement is an option, which is true because the most of the data that comes out of valve repair would be very very Western data, and even the Western data is changing today. So for mitral regurgitation in 2020, there was a landmark paper by Mark Gilinov from the Cleveland Clinic. And I have personally communicated with Mark on this issue. I have met him at a couple of ISMICs. I have spoken to him about it. And today, with multiple other trials like the Estimate trial or a follow-up study from the same Cleveland Clinic has gone on to say that a mitral valve replacement probably is a better freedom from reoperation or freedom from a reprocedure at 8 to 10 years rather than a mitral valve repair, because repair is only going to hold 5 to 6 years. So for a healthcare system where it is all Medicare, credit card, unified healthcare, you can probably afford to go in and get into a cardiac clinic and get a re-op at every sixth or seventh year. But in this part of the world where you replace a valve as a lifelong fix, I would any day say that a replacement is a better strategy scientifically, hemodynamically, cardiac wise for any patient.
Thank you, Dr. Vishnu. We have a few questions. So, first question is, what about the place of traditional alcohol when it comes to cardiomyopathy? So, this is from Dr. Kweth from DRC.
Okay. What is the traditional? See, I would not be the best judge to say whether you should have traditional alcohol or not, but it has been proved beyond doubt in multiple studies that any form of alcohol will predispose you to have cardiac dysfunction. Any form of alcohol, that can be some traditional drinks have been compared in them. I'm not all, but all commercially available liquor that is there, and that myth around red wine kind of giving you a healthy heart has been busted. It has been long busted. So no form of alcohol is going to give your um, heart any benefit. If you are a chronic consumer of alcohol, it will only going to damage your heart. Whether you want to have a good laugh and have a drink, that's a completely different story.
So,
But
sir, that
there's no scientific claim to it. There's no scientific claim to back it that a red wine, a gulp of red wine is going to give you a healthy heart. Now, so the next would be, how do you manage the risk of bleeding when you place a patient on high dose of antiplatelets as 600 milligram aspirin and clopidogrel? You do not. When you're loading somebody for a I mean, in the lack of a percutaneous coronary intervention, you are loading somebody with antiplatelet drugs. You are loading them with 600 milligrams of aspirin and 300 milligrams of clopidogrel, knowing that they will carry a very high risk of bleeding. But that is your best bet to open his coronary artery blockage. Because if you really want to control the risk of bleeding, you only control the risk of bleeding in a live patient. If you get the butt of my joke, because if your patient is dead with a myocardial infarction for the lack of a PCI, whose bleeding are you going to control? Could you please tell me the primary indication for using sacubitril valsartan? Sacubitril valsartan would probably should be started at the lowest possible dose. So I very frequently, because of the Indian population, start them at half a tablet, which is 25 milligram of sacubitril valsartan once a day. Build it up over a week. Kind of go up to 50, then up to 100. And I would rarely go beyond 100 milligram once a day in terms, or 50 milligram twice a day in terms of sacubitril valsartan for anybody with a ejection fraction less than 45%. So ejection fraction less than 45%, high anti-proBNP levels. I would very interested in starting sacubitril valsartan at the lowest possible dose of 25 milligram, build up to 50, and then up to 100. What's a relative epidemiology? Thank you for the great presentation. Thanks so much, Dr. Edugbo. Please, from your experience, what's the relative epidemiology of occurrence of CAD for Africans, Asians, and Caucasians? Are there differences in surgery success rates in these different populations? Um, Epidemiology of coronary artery disease for Asians and Africans would largely be, uh, the genetic predisposition to having a coronary artery disease, which Caucasians have lesser. But Caucasians would be more affected by coronary artery disease simply because of their food, dietary, sedentary lifestyle, and other ill effects of the developed world. In terms of surgical success rate, I would say they are kind of very comparable world over, whether it is done in Asia, whether it is done in America, whether it is done in anywhere in Europe, whether it is done anywhere in Australasia. The surgical success rate would be very similar, anything upward of 90% in general, across units, across pathologies, across the seriousness of disease. I would expect somewhere around a 5 to 7% risk of morbidity and mortality after coronary artery bypass grafting procedure. And it is same for either stenting and or cabbage. Okay. Think of in the case or care of HIV TB patients, are there any special considerations regarding drug interaction in the event of interventions? Well, they are almost all anti-tubercular drugs are known to be pro-thrombotics. So, in anybody who's suffering from tuberculosis, it is not a bad strategy to put him or her on a baseline dose of antiplatelet like an aspirin 75 milligram and or a 0.5 to 1 milligram of warfarin once in a day, because all anti-tubercular drugs are known to cause some or the other form of prothrombotic events. In terms of HIV, yes, a lot of the antiretroviral therapies are CYP3A4 metabolized drugs, and they will interact with a lot of your um, cardiac medications. Predominantly, they will interact with your warfarin, they'll interact with your heparin or low molecular weight heparin that you take, they'll interact with any ACE inhibitor that you are on, they'll interact with your beta blockers. So you have to consult the concerned, antiretroviral therapy clinic or the infectious disease specialist as to the specific interaction of the antiretroviral drug he or she has been put on, and accordingly alter the dose of the cardiac drug. But more often than not, remember, you have to increase the dose of warfarin, decrease the dose of beta blocker. That is basically the thumb rule that I use. Any more questions? I'll be very happy to answer.
Sir, I wanted to, dig deeper on Dr. Onana Paul Edugbo's question, like relative epidemiology of occurrence in CAD, coronary artery disease, for Africans, Asians, Caucasians. So, in the you had conducted a masterclass around it, and one leading point that you had made, if I'm not mistaken, and if I recall correctly, was that rather than physiology, it was more about lack of detection and lack of trained manpower that uh,
Lack of detection is one. No, he's asked what is the relative epidemiology of occurrence. So epidemiologically, it is in Africans and Asians, it is basically a genetic predisposition. In the Caucasians, it is their extremely sedentary lifestyle, fat-rich food habits, a gulp of alcohol with a huge burger which is cheese loaded. So that is the Caucasian CAD. Vis-a-vis the Asian or the African CAD is more like, genetic predisposition. Yes, there is a certain amount of heavy meat eating habit in the African population and some Asian population as well, which predisposes them. Um, in terms of occurrence, if you ask me, not epidemiology, only occurrence, I would say the numbers in Asia and Africa are hugely underrepresented. And as I had said today as well in the presentation, in the very second slide, that a lot of our problem is because they are underreported and often underrepresented, because quality diagnostic facility imaging facility are not available. So if they are saying that there is 1 million death in the sub-Saharan region annually because of cardiac disease, honestly, if you wrap up the the investigating modalities, or if you have the right modalities in place, you'll probably say the number would be about 3 million tomorrow. So the numbers are often underrepresented. The occurrence, yes, but the epidemiology would largely be we are more predisposed to coronary artery disease in the Asian and African population.
Okay, sir, I have a question. You had shared a diet chart that 2, 3, 4,
Yeah, yeah, two, three,
four,
four,
five
five.
pyramid.
So it's two legumes, three fruits,
Yeah,
four
yeah.
different types of vegetables, and five different types of grains.
So, like the normal perception is that in India there is a huge population of vegetarians and who typically follow this chart. And still, like in the last 2, 3 decades, we have also a lot of occurrences of cardiac
So
incidents.
you have
Explains that
introduced
anomaly.
you have introduced the you introduced the age-old Indian who was having two legumes, three fruits, four veggies, and five grains from cooking with mustard oil, or from cooking with oil that has been naturally resourced, to cooking with artificial oils, and you only made him to believe that adding some omega 3, 6, 9, 12, 15, I don't know where the omega number will come to an end these days. So you basically told him that the same oil that we have used to fry our Kentucky Fried Chicken is going to give you excellent result with excellent, cardiac health. And the Indian has believed it. You've packaged it well. It was omega 3 fatty acids. Now I hear there are omega 6 fatty acids. Tomorrow there'll be omega 9, omega 12, if you really catch the joke. So rather than chasing the omega fatty acid numbers, it will be much more beneficial if people just went back to the traditional way of using olive oil, mustard oil, give up on using all these clarified butter and all these um, modified omega 3 loaded is essentially packaged artificial cooking oil. So if you can really give up on that, you would have killed half of the heart disease in this country.
Sir, I mean, if I want to ask a question, and I hope it does not come across as
Well,
stupid, but
it's okay.
these days we also see often incidences where very fit people, regular into fitness, even sportsmen, like even
Very,
international athlete like Shane
very
Warne,
fit
so
people,
have sudden cardiac incident and heart failure and death.
very fit people does not mean um, a very heart healthy person. No gym in this country. You go to any gym, you go to any good gym in and around the vicinity. If you want to join a health or fitness or a gym or a fitness center, they will only ask for a medical certificate. They will not ask for a they'll not ask for a blood workup. They'll not want to know your triglyceride level. They would not want to know your homocysteine level. They would not want to know your CRP. They would not be concerned about your body fat percentage. Yes, they'll have one of those fancy calculators where you kind of hold them and it'll kind of vibrate for a while, telling you your body fat percentage. You will still be taking a lot of supplements, most of which are non-FDA approved, unregulated, and it is a billion-dollar industry in this country. Those huge, jars with those misty powders. You don't know what makes them. Most of these people will only focus on developing very good or very intense muscle mass, but you need to understand that your heart is also a muscle, and your biceps are enlarging, so is your heart muscles. When your bicep grows, it is probably called fitness. When your heart muscle hypertrophies, it is called as hypertrophic cardiomyopathy, unfortunately.
Okay.
So there a lot of it people coming to sportsmen. I understand where that comes from. It comes from the recent Commonwealth gold medalist shooter Jaspal Rana losing his life only about last.
And so Shane Warne, the wizard,
Hmm.
a couple of years back, he was an international
I was
athlete.
I was I was so shocked and so sad at Shane's passing away. But Shane one is that gentleman who smoked his way through life. He was a typical Australian bloke. He had a good life. He had a good time. He was more like the coronary artery disease of the white man. Bad food habit, crash dieting. So he had his reasons too. excess intake of alcohol. So he had his own reason to, die. Shane is not a discipline. Yes, he is the absolute master at spinning that ball, but then he's not a disciplined cricketer. He is somebody, have your drinks, have your food, have everything else. All the examples you should not set for young people. So Shane has been that is extremely sad. I was in Australia at that time when Shane won past. So it was kind of a, at least in Sydney, it was kind of a national mourning for a couple of days. So, yeah. So extremely, no, I would probably say that there have been more fit, sportsmen that have had cardiac events. If I cannot recollect very well his name, I'm sure his name is either Eriksson or Eriksen. Is the Scandinavian footballer who collapsed in this World Cup. He just had a small fall, and because he had an implanted ICD, he was somebody who had a similar thing in the Euro 2022. Euro 2020, he had a cardiac event on the pitch. He came back in 2022, started playing football, represented his country for 4 more years. This year in the World Cup, he had a cardiac event because he had an ICD. He just had a small kind of a dizzy episode. He went off the field, was diagnosed to have a sentinel cardiac event, and he's been doing well, but he has been taken off the team. It is the is the Danish footballer or it is a Swede footballer, Ericsson. Can't recall more details than that. So
I
there,
think
there, there is a role of, when I say that there is a role of implantable cardiac devices, yes, there is a role of this pacemaker and ICD device in preventing death. So he's probably got his ICD in 2020, and he kind of then had a cardiac event in 2026. So for 6 years, the ICD did nothing. On one fine day, he had a arrhythmia. It just triggered, defibrillated him, got him back. He just felt a little dizzy, went off the pitch, and he was alive. Because the same footballer had a CPR on pitch when he survived his first cardiac event. So an ICD may be a life-saving, modality for certain group of people that have cardiac arrhythmias. And athletes, as they know, as it is called, athletes are known to have a slow heart rate. It is called as athletic bradycardia, and it has been known to the medical fraternity for a very, very long time. Because of extreme high cardiac output that they want, their hearts naturally slow down. Part of it is because of the hypertrophy, part of it is because of increased vagal tone, part of it is a lot of other complex physiology put in place. So there is something known as athletic bradycardia. Today, with wearable devices and everything else, and more monitoring devices present right at that moment, we're probably detecting more arrhythmias than you've ever detected. Something as simple as your Apple Watch can detect your atrial fibrillation, and people have benefited from it.
so I have one more question, and it is more like, as you said, that the last holy grail is a heart transplant, but that is also being dependent on an organ, suitable organ being available, and then
Yeah.
the patient in between, they are on LVAD. So, can LVAD or the technological advancements in that direction, can it be a replacement for heart transplant altogether? Like if there are more modern
In
devices?
certain aged people, or people above the age of 55, LVADs have gone on to replace heart transplants to a reasonable extent, because LVADs have today become what is known as a DT, or a destination therapy. So for people who are wishful of living no more than 15 years, LVAD can be a permanent solution, because LVADs can run for 15 years without any hiccup. We currently have a young gentleman from Lebanon who is with us, was implanted in LVAD in 2016, and in the 11th year today, now that he is 31. He was a late teenager then. Today he's 31, and today he's come up for a heart transplant registration. We've registered him with the National Organ Transplant Organization here, and potentially, as his LVAD kind of nears the end of its life, or his LVAD kind of has been developing some complications in terms of battery malfunction and other things. So now is probably the time for him to continue on the LVAD for a few more years, or maybe a few more months, and get a transplant. So LVAD can be a very reasonable solution for people that are wishful of living no longer than 15 years of good quality life without being on antiplatelets or without being on kind of immunosuppressants. Just being on a simple antiplatelet and anticoagulant is going to be enough for you.
And sir, compared to, let's say, a live donor transplants like liver or kidney, I mean, heart transplant comes from a cadaver. So,
Yeah.
how far is medical science advancements? Like,
So
like,
see the
are there
two things
second? No, no. My
that
question is first, is there a hope for these second generation LVADs, like which do not
or see there are
time
three things in the heart transplant space that is going to revolutionize it. One is when we are talking about some more question. Okay, so when you're talking about deceased donor transplantation, so we need to talk beyond that brain dead, and we need to talk about circulatory death or DCD hearts. So people that are in the hospital that are not brain dead, that is just had a cardiac arrest and have passed away, rather than calling their family or where you expect a cardiac arrest might happen maybe in the next 8, 10, 12 hours, rather than we can bring in the family, prime them up that he's a healthy donor whose heart is healthy, but because of other ill effects or because of sepsis or some other ailments in the body, his heart is going to not, or he's probably somebody who's predisposed to a circulatory death. So in those cases, his organs, after they have stopped beating after a 5 minute no touch period, we can go on to reanimate their heart, retrieve that heart, and kind of implant it in anybody who's in requirement of an heart. That would mean potentially every hospital death in a non-contagious disease patient is going to turn that patient to a potential donor. So we can at least double the pool of organs from deceased donor transplantation if we are talking of including the DCD along with the DBD or the disease or death after circulatory donation after circulatory death and donation after brain death into the complete uh, you know complex of disease donor transplantation. A. B is going to be organ transport machines or machine perfusion, which will make, say, a donor from French Equatorial Africa could donate an organ for a transplant somewhere in the East Coast in America. It is only possible because that heart was put on an organ care device like this, which is the Transmedics OCS. This heart is beating. It is outside a human body. It is not connected to any human body. Artificially, blood is being pumped in, and this heart is beating, and it can be done for 8, 10, 12, 15, 16, 18, 24 hours, more than the number of the digits in the omega fatty acids. So it can beat for at least 12, 24 hours while it is being transported. So it also doubles your pool of organ. And the third thing, which has become a reality today, would be xenotransplantation of organs from genetically modified pigs being implanted into people. There are at least two xenotransplanted heart recipients that I'm aware of who have gone on to live. One has gone on to live 10 months and the other has gone on to live a little more than a year. The first was basically a convict on death row who had a xenotransplantation on him. The second was a patient somewhere in Ohio or Illinois, if I'm not mistaken, who had a heart transplantation from a genetically modified pig. So
uh,
xenotransplantation, machine perfusion, donation after circulatory death. These are the three things that are going to change the deceased donor transplant space completely in the coming decade.
so, is there any scope of technological advancement in LVAD, like that? If something keeps,
LVAD has today moved from LVAD has moved a lot of technology from the generation one, um, you know, centrifugal LVAD. They moved on to axial flow LVADs. They have now moved on to completely maglevs or magnetically levitated LVADs with the HeartMate 3, which has minimized the incidence of stroke and thrombosis and blood clotting to kind of be a 15-year therapy. There is some research that is going on to developing a biventricular total artificial heart. There is a total artificial heart called a syncardia, but there is more research going to developing a completely magnetically levitated total artificial heart that can be implanted, where it like a L and R bed and can kind of support the function for years together. So
yeah.
that research is ongoing, which would mean that anybody out there, if they've got a heart failure, they can come in, buy the device, get it fixed, and get going. So you are totally, free from the heart transplantation. But I would strongly believe that there would be no device that we human beings can engineer as beautiful as God's created heart. which will go on to replace it completely. So heart transplantation will be there to stay for at least my active years of medical practice, which will be another 20, 25 years.
And sir, would xenotransplantation, like you mentioned, we have limited success, 10 months or more than a year, but like,
So
do we see
Xeno
this
is only
happening in your years of practice?
Xeno is only going to improve with the passage of time. Xeno is only going to improve.
Okay. So we have another question from Dr. Innocent Zili. What is the best approach to manage peripheral edema, swelling of the feet in a patient with HIV, PTB, and with hypertension?
With hypertension,
Yes.
you got to do a recent echo. You got to identify what's his heart function. If his heart function is beyond, is fallen below 20%, there is no way you can manage the peripheral edema. That peripheral edema is there to stay. Diuretics can only act till a certain limit. You cannot give an amount of diuretic to make anybody have their peripheral edema completely go away. So if it is completely failing hard, where there's a lot of fluid accumulation in the body, one of the strategy might be using a device like Aquadex, which is a miniaturized filter device. I can show you what an Aquadex would look like. Give me a sec. Is my screen visible?
Yes, sir.
So this is the Aquadex Smart Flow system, which is a very miniaturized device. You know, show the device. Too much of a. Oh, goodness. I want a professional network. Yeah. Yeah. So this is basically the device, which is a prime volume of 15 mils. It can work on people with heart failure, can remove anywhere between 60 to 100 ml of fluid every hour. So if there is an intractable heart failure patient whose peripheral edemas are not going away, come what may, whatever dose of diuretics you are giving, then Aquadex might be a logical option where diuretic therapy is failing. But if his heart ejection fraction is less than 20%, I would strongly believe that this is end game. You don't have much space to kind of offer him. If he is hypertensive, there are a lot of options. You can put him on an RD, you can put him on a diuretic, you can probably put him on an ambulatory peritoneal dialysis. But all of that would, in somebody with a communicable disease, would predispose him or her to spreading or having more chances of spreading the infection. No matter what you say, if you have a device in the body cavity which is open to the world, it is not going to be a very feasible solution or acceptable solution. So somebody with HIV who's got a bad peripheral edema, you have to do a quick echocardiogram and absolutely be sure about the cardiac ejection fraction. The other thing I am very wary of is this 35 to 40, 30 to 35, 25 to 30, 20 to 30, or 20% ejection fraction is a completely different story to 30% ejection fraction. So I would rather say that have a ejection fraction measured by Simpson's method or planimetry or any given method, and have a fixed number. And if that number is less than 25, preferably less than 20, then there is not much you can offer this heart.